This portion of the lecture is going to be about clinical exercise testing and a little bit about programming. You're going to learn most of programming from 4450, but I'm going to point out some key differences. To be able to work with an individual that has a chronic disease or disability, it's really important that you do have an understanding about the disease, about the characteristics of the exercise testing protocol, and also have an understanding about normal and abnormal responses. And so the resources that you have for all your classes are going to be helpful, and the guidelines will also be helpful. In a clinical setting, the process of working with clients involves something called POEM, or Problem-Oriented Exercise Management, that it has 5 steps. And it involves the process of making SOAP notes. And the SOAP notes, you'll see there's an SOAP, and the 5th step is planning for periodic reassessments. We're going to look at the components that are part of this process, and you can see the use of SOAP gives you an assistance in what am I supposed to be collecting from my client at that time. So I want to remind you, this is problem-oriented exercise management, problem-oriented. The only way that you can determine what the problems are to do an assessment of the subjective information. So the subjective information is what is the current status of my client. That involves a number of components. How long has the person had the diagnosis? What kind of information that person can give you that is from their perspective. It is related to what barriers get in the way, why I can't exercise, what kind of symptoms that the person has, what kind of interest that individual has, what they might like or not like to do. And also, let's see here, what kind of barriers get in the way, why that person might not be able to exercise. This is all subjective. More subjective information. If you want to identify a program or make a program, you want to know what is a person's current level of physical activity. And you start with a broad type question and then move down to a focused question. So a broad question might be, how often do you walk? And a person says, well, I walk kind of, I walk. And you can follow up with, how much do you walk each day? How often do you climb the stairs? What do you do for exercise, physical activity? Or how do you define exercise? This type of questioning defines the expectations that the person is going to give you subjectively. So a broad question is, can you describe your activity? And they'll say, well, I walk sometimes. You want to dig in a little bit more and ask some focused questions, because saying that a person walks might mean it's completely vague. And to give them an activity program that's going to be feasible and realistic, you want to know what they're currently doing. So you're going to follow up with more detail. Easy way of asking a broad question is, what does a typical day or week look like? You want to make sure that you understand what kind of symptomology that individual has for limiting their participation. It's easy to say I'm short of breath, but is that because I just haven't been active? Or is it related to a lung function? Is it related to asthma or COPD or emphysema? So symptoms can be related to a condition, and they also can be just general deconditioning. So when you're not very fit, you do get a little short of breath going up a couple flights of stairs. and it's not necessarily related to any specific condition, it's just general deconditioning. The qualitative descriptions are how you get more detail about that type of symptom. And how long does it take you to, how long do you rest before you go back at it, is getting a general overview of recovery time. So symptoms can be related to a functional, can be related to a disease, or it can be related to some deconditioning. And this again is subjective information that the person is giving you. Now, example could be a person could say, I can walk 10 minutes, but then I stop because my legs cramp up. You might want to ask, well, how long do you recover before you can start up again? This will give you an idea where to start for an exercise program, and also what kind of exercise test might be appropriate, and if the person does need further testing. You want to make sure that you pay attention to neurological impairments where a person, for example, that has diabetes might have numbness, tingling, pins and needles associated with diabetes. That would mean that perhaps a walk test might not be appropriate. You also want to be looking for signs of instability where you review or watch a person walk and see if they are at risk for falling and perhaps they need a specialist, or they just might need some leg strength and balance exercises. So the difference with chronic people that have a disease is that you're also looking at these other components about balance fall risk. Individuals might be better served with tests of physical functioning, which you have had an opportunity to look at some of those assessments, the tug test, chair to stand, some assessments of leg strength, 10-meter walk test, or an instrument that looks at how a person does their activities of daily living. And this is more in those activities of daily living assessments or instruments are often done in a clinical setting with physical therapists or an occupational therapist. Now these are listed as O. So subjective is what the person tells you. O is what you objectively collect as data. The type of exercise tests that you might use in a clinical setting would be done primarily for diagnosing ischemic heart disease, looking for abnormal symptoms, assessing blood pressure response or cardiovascular response, and there are a number of different exercise tolerance tests that can be done. And I want to show you a couple in the next slide. Got ahead of myself a little bit. The reason for doing clinical exercise testing is to diagnose cardiovascular or pulmonary disease, look at the responses such as shortness of breath, exercise intolerance, exercise-induced bronchospasm, rhythm disorder. Prognosis would be to assess the risk of an adverse event and evaluate the physiological responses of blood pressure, heart rate, VO2 max, and ST segment depression, etc. There are contraindications to symptom-limited maximal exercise testing, and there are absolute or relative contraindications. And if you have the 11th edition, you're looking at box 4.1 on page 116, and this is also something that you want to mark in your, perhaps put a little tab in your manual so you always know an absolute contraindication means that you will not do it if someone has unstable angina, if they are actively in a disease process of having a myocarditis, aortic dissection, or any of those that are listed. Let's see here. The safety is physical disability that precludes safe and adequate testing. Now that one is left with a little bit of interpretation, and a physician is going to be making that decision, right? The relative contraindications mean that a person is not absolutely, it's not an absolute don't do the symptom limited maximal exercise test, but it's possible that unless a person is in the right setting, that it would not be safe to do. So if someone has a mental impairment with limited ability to cooperate, it's possible that you just can't do that max symptom limited maximal exercise test, right? So absolute versus relative. Absolute is thou shalt not do the test. Relative means you might be able to do the test. The appropriate test is always a challenge. Your goal is to get to somewhere between 8 to 12 minutes if you're doing a symptom limited maximum exercise test. And figure 1 on page 120 gives you a list of treadmill protocols and also cycle ergometer test. And this is a nice figure which identifies the MET value, the approximate MET value on the first column that corresponds to the different stages. And you'll see that a ramp protocol, which is the third column, it's on a treadmill. Every 30 seconds it starts the speed and the grade changes. So initially the first 30 seconds, half a mile an hour, then from 30 seconds to 60 seconds, 1 mile an hour, and then from 60 seconds to a minute and a half, you're at 1.5 miles an hour, and you'll see that you progress till you get to a constant speed of 3 miles per hour, and then the grade increases every 30 seconds. And a ramp test is something that is has become more prevalent to do, especially for diagnosing ischemia. The modified Bruce and the Bruce are both listed, and there's also a modified Naughton and a Naughton test. And you'll see that the modified Naughton is CHF or for heart failure, chronic heart failure. So that's a real common test that's utilized for individuals that have chronic heart failure. Now, as you look at each stage, you'll see that if you draw a line from the stage to the far left, you have an approximation of the MET value. So the modified Bruce can get, if someone gets to 22% grade, 6 miles per hour at 3-minute stages and completes that whole thing, they are at about 20 METs. If they can only make it 2.5 miles per hour and a 12% grade, or their 1, 2, 3, 4th stage, they're right about 7 or 7.5 METs. So you can get an idea about which one of these protocols are going to be appropriate based upon a person's estimated MET max. Hopefully that makes some sense. When you're doing clinical exercise testing, you are assessing, and this is page 121, and you can look at the before, during, and after exercise, that with each stage you are getting a resting EKG, you're monitoring it supine and in the position of The exercise test, you measure it continuously, and then you take a strip at the last 5 to 10 seconds of each stage, or if you're doing a ramp, every 2 minutes. And then post the end of the test, you're monitoring it continuously after 60 seconds of recovery, and then you monitor it, which means you watch it on the screen, but you take a strip after 60 seconds of recovery, and then every 2 minutes you take a strip. Heart rate, you can see that there's recommended best practice of when that should be taken. You monitor it continuously, and you can do that with an EKG. Or if you don't have an EKG, which if it's clinical, you're going to have an EKG, when you take it, basically you get that information off that strip. You measure the blood pressure in supine position and then position of exercise, before exercise. You record it the last 30 to 60 seconds at each stage, and then you meet after somebody is done completing the exercise test. You get it, boom, 60 seconds immediately post-exercise, and then 60 seconds, and then every 2 minutes. So you're really busy doing these clinical tests. You're monitoring signs and symptoms continuously. You record as it's observed during the time. You monitor them with perhaps, and that is if somebody has chest pain, leg pain, and there is an angina scale if somebody has chest pain. And the ratings of perceived exertion, you're measuring that during the last 5 to 10 seconds of each stage or every 2 minutes, and then you get it at peak exercise. And what the beauty of getting your RPE is that you can use that for making exercise recommendations. If you know how somebody is responding to 7 METs, you know if that is a 19 that you will not give them an exercise protocol or program at 7 METs. You'll do it lower than 7 METs. So that clinical information is really, really helpful for exercise programming. This is the modified bulk protocol. And here you can see that you have a self-selected speed, and every minute it bumps up. And this is this is a modified, and this is for a max VO2. And on the right-hand side, these are just a summary of a variety of different exercise tests that you don't see, like the LSTED is not listed in the ACSM 11th guideline, the bulky wear is not, but the modified and the Bruce is. And here you have the time. The white is the speed in kilometers per hour, and then the dark is the grade. So it says from minute 0 to minute 3, the Bruce is 2.7 miles per kilometers per hour, and 10% grade. So there you go. Figure 4.3 on page 124 has a couple different scales that are used. These are for angina, claudication, and dyspnea, or shortness of breath. And a scale of 0 to 4, these are if people have symptoms and you know that they're getting assessed for cardiovascular disease or ischemia. The angina scale is going to be available or utilized in that assessment. Claudication is a discomfort or pain that's felt in the lower body, in the calves and the feet, and that is with peripheral artery disease. And dyspnea, it would be if somebody is also having shortness of breath during their cardiovascular assessment. I will say that I didn't mention the Borg CR10 scale in the picture, and that is on page 123, figure 4.2, and this one is utilized very commonly for people that are getting assessed for pulmonary disease. And that is a real handy assessment. So the Borg CR10, I can't remember what CR is, darn it, but that's pretty commonly used in that kind of assessment. Reasons to stop an exercise test, and that's going to be on page 125. Why do you terminate a symptom-limited max exercise test? Well, you get trained to read an EKG, and you look for indications of ischemia. And one is going to be that ST segment elevation greater than 1 millimeter in leads without Q waves that are seen prior to doing your test. And if somebody is getting assessed after they already have had a myocardial infarction, then if you see ST segment elevation, you're going to stop. You'll see a drop of blood pressure. Remember, we're assessing blood pressure every stage at the end of, especially, except this is not including ramp, you're assessing the systolic blood pressure response. And if you see a drop in pressure, despite increasing workload, you are going to be concerned about that, especially when you see other causes or indications of ischemia, which be that ST segment changes. If somebody has angina that they say, oh man, I'm a 3 with my chest pain. If somebody is dizzy or feeling lightheaded, if they look pale or blue lips, if they have an arrhythmia that is indicative of an electrical change, whether it be VTach or some kind of a block, they're going to start to often feel poorly perfused or get cyanotic or very pale. Or if somebody says, I want to stop, you stop. You can encourage them a little bit, but you want to make sure that you are listening to them. If you have problems with your equipment, you stop. Relative indications would be if you have horizontal or downsloping ST segment, and this is again something that you get trained with clinical exercise testing. You see a drop in the blood pressure, more than 10 millimeters of the systolic blood pressure without seeing ischemia. A person is starting to have chest pain, they're having leg cramps, wheezing, they're having an extremely high blood pressure response of greater than 250 for systolic, or diastolic greater than 115, or if you're assessing their oxygenation, if that gets less than 80, and that's going to come into play later on with some of our pulmonary diseases, it's a relative indication, and that means that you make the decision to stop it. It's not absolutely stop. You might keep going. Now I'm going to tell you that these are clinical, so you're going to have other folks there to help make that decision, and this is where experience comes into play. So those are objective information. So once you have all of your objective information, then you're ready to say, what are my issues? What are the issues, the problems, the assessment? So remember, this is problem-oriented exercise management. You got the symptomology, you've got the objective information, you've got the subjective information, the objective information. Now you say, all right, let's take a look at this and see what kind of problems that we're going to focus on. So to consider that program, you're going to look at limitations, whether they be physical, emotional, psychological, physiological. You're going to look at the disease and the safety of exercise. You're going to identify what does the client or the patient prefer to do. Is it walking, water? Going to get that information. You're going to make sure that you have a clear agreement with your client that they understand symptoms, and then you're going to identify what is going to be helpful for my client to be able to adhere to that exercise. These are all looking at your assessment. You're going to develop the program with short-term and long-term goals, evaluate what kind of medications that person has on to make sure that you understand completely and the client understands the impact of medications on their exercise response, and they need to understand the risks and the benefits of exercise. This is the P, the plan, the program. So risks and benefits involve the risk for injury, the risk for the use of energy that they have. Do they have money? The cost of the exercise or the risk has to be less than the benefits that they get for that exercise. Developing a plan or strategy for monitoring the progress is important also. Now, the monitoring may include the frequency, intensity, and duration, the number of days that they participate. The clinical responses might involve those measures specifically associated with the disease. Perhaps it's blood glucose, maybe it's heart rate response, maybe it's shortness of breath, maybe it's fatigue, maybe it's headache, nausea, anything. Okay? And then monitoring their fitness, and that could be some of those functional exercise tests that you watched, and it might be just some general perception as well. The education of the participants or the patients is really important so they understand what's normal and what's abnormal. And finally, the patient should understand how to be safe, what a normal response is to an abnormal response in terms of symptomology, when they should contact the physician or you, and they should understand clearly how to monitor their exercise.